Good morning everyone. Today, with the continuation of the last class, we are going to discuss the chronic suppurative otitis media. I am Dr. Azmat, Department of ENT. Let us see what is chronic suppurative otitis media. This is very important topic for the examination point of view, as well as most important with the clinical point of view. Okay. So before that, what is middle ear cleft? So middle ear cleft is mastoid air cells, antrum, adytus and attic with middle ear and eustachian tube. All these together called as middle ear cleft. This antrum, adytus and attic, this is the key area, and middle ear cleft is along with this mastoid air cells, middle ear and eustachian tube. So for everything, every disease, you need to know what is middle ear cleft and what is the lining epithelium of the middle ear cleft. This is also they used to ask for the MCQ in the pre-PG entrance from the lining epithelium. Anterior inferiorly it is lined by ciliated columnar epithelium, and posteriorly it is cuboidal epithelium. And the attic means the epitympanum and mastoid air cells, they are with flat non-ciliated epithelium, that is also called as pavement epithelium. Okay. So definition, when it comes to definition, what is CSOM, chronic suppurative otitis media, shortly called as CSOM? It is a long-standing infection of the part or whole of the middle ear cleft. The middle ear cleft, nothing but mastoid air cells, attic, antrum, adytus and middle ear mucosa with eustachian tube, and this is characterized by a continuous or a intermittent discharge through a persistent tympanic membrane perforation. There will be a tympanic membrane perforation. Okay, so this is the definition. You have to write it in the exam the same. So epidemiology, the incidence is higher in developing countries like India, Bangladesh, Pakistan. Okay, and the predisposing factors, obviously poor socio-economic status, poor nutrition and lack of health education, and it affects all, both males and females, and it is prevalent in all the age groups. Okay, you can see a CSOM in any age group. So in India, the overall prevalence rate is 46% in rural and urban is 16%, and this is the single most important cause of hearing impairment in rural area. Okay, the ear discharge is most common symptom in the rural area along with hard of hearing. So types of CSOM, chronic suppurative otitis media, is mainly two types. One is safe type or tubotympanic disease. The safe type is also called as tubotympanic type disease, and it is also called as mucosal disease. So you should not confuse the words, the terms. Okay, safe type, tubotympanic type, mucosal type, they are all same. Why it is called as safe type? Means it is less commonly associated with the complication like intracranial and temporal complications of the you have various complications. In subsequent classes you will know what are the complications of the CSOM. So you have associated with very less number of complications with this type of CSOM. So that is called as safe type. Tubotympanic, why it is called as tubotympanic? Means tympanic means middle ear and eustachian tube most commonly affected, so it is called as tubotympanic. Okay, and mucosal, why it is mucosal? The mucosa, okay, where, and it is again active and inactive type. Active means actively discharging, inactive means there is a gap or pass. Okay, let us see this terminology again. And what is unsafe type of CSOM? What is unsafe? Means it has associated with high rate of complications, okay, like facial nerve palsy, lateral sinus thrombophlebitis, meningitis, intracranial and intracranial and temporal complications of the CSOM. It is associated with high number of complications. and it is called as atticoantral also. Why atticoantral? Means it affects the attic region and antrum. Okay, that's why it is called as atticoantral. Squamosal, why it is called squamosal, and safe type, why it is called as mucosal. In subsequent classes I will explain you. Right, again it has active and inactive and quiescent. The terminology I will explain. The main here you should understand is this is a safe type and unsafe type. Safe type is also called as tubotympanic disease, and it is also called as mucosal. Unsafe type, it is called as atticoantral and squamosal also. So if a question comes as explain the squamosal type of CSOM, you should not confuse. Okay, and if they ask explain the mucosal type of CSOM, the terminology you should aware of it. Okay. So in this class we are discussing the safe type, the tubotympanic or mucosal type of CSOM. Okay. So as we said, the disease confined to eustachian tubal and mesotympanic area. So that is, it is called as tubotympanic. Tube means eustachian tube. Okay. And tympanum means middle ear. So it is confined to mesotympanum and eustachian tubal area. Okay, it presents with a central perforation. Okay, it presents with a central what is central perforation? What is a perforation? I'll explain. And it has a minimal risk. It is associated with the minimum number of minimum risk with the serious complications. Okay, and the disease is usually starts in childhood, and so that's why this disease is commonly seen in child group. And there won't be any osteitis or osteomyelitis. Osteitis means inflammation of the bone. Okay, and osteomyelitis, inflammation of the bone marrow. It is not associated with osteitis. Okay, but the atticoantral disease, it is associated with osteitis. That's why you will be having foul smelling discharge in the atticoantral type of disease. But tubotympanic type of disease, you won't get any foul smelling discharge. Okay. Etiology, why it happens. Okay, what is the etiology? Let us see. The first one, the infection spreads via the tympanic membrane. Okay, most commonly a repeated attacks of ASOM. Okay, and as last class we discussed that if you treat inadequately, improperly, and the host resistance is very low and the virulence of the disease is very high, the problem will be persistently will be there. Okay, and sometimes it is also associated with a post-traumatic perforation of the tympanic membrane. For example, if you have an injury to your tympanic membrane, so there is a rupture of the tympanic membrane. So that rupture due to inflammation or infection presents nearby surroundings, and the tympanic membrane won't get healing. Okay, it won't heal, and there will be a perforation, and if the infection spreads to middle ear, then again it will cause discharging ear. Okay, but the most common is it is following the repeated attacks of ASOMs, and sometimes following the exanthematous fevers like measles. Okay, again it causes acute otitis media, and this acute otitis media, as we discussed earlier, the stages of the ASOM, it leads to a stage of suppuration where it leaves a central perforation and it will become permanent. Okay, and it permits the repeated infections from the external artery canal, and it leads to CSOM. Okay, and sometimes the middle ear mucosa is exposed to the environment and it gets sensitized to dust and pollens. So it is allergic etiology. Okay, and it causes a persistent ear discharge. Right, from where infection comes to middle ear? As we discussed, the eustachian tube, the anatomical variations, the more common it is in children, it is straight, right? So from there the infection, it comes to middle ear, and again the infection from the tonsils, adenoids, and from the sinusitis, and regurgitation of the fluid. The fluid enters to middle ear easily via the eustachian tube. Okay. And as we discussed, allergy to eggs, fish, milk, anything, pollen, whatever the allergen. Allergy also, it causes CS1. So when it comes to bacteriology, what are the organisms that most commonly involved in the CSOM? That is Pseudomonas, Proteus, Escherichia coli, Staph aureus, bacteroids, and anaerobic streptococci. Sometimes if the ear discharge is associated with anaerobic bacteria, it causes a kind of foul smell also, but normally in CSOM the discharge will be non-foul smelling. Okay. Clinical features. How a patient presents to you. The most common clinical features are ear discharge and hearing loss. Okay. What are the characteristics? Let us see. So if the discharge is it has a mucoid content, it will string. Okay, right. And the discharge will be non-blood stained always. Okay, please do remember the discharge will be non-blood stained, and it is most commonly it is intermittent type of discharge. And hearing loss. How much hearing loss? Usually, see, it is affecting the middle ear, right? So middle ear is affecting means it is a conductive type of hearing loss. Okay, and the hearing loss will be from 25 to 50 decibels. Okay, sometimes it might be normal ear. He can hear normally due to small and dry perforation. Okay, and another feature is called as round window shielding effect. Okay, you can hear better with the discharge. Why? Because and here the round window shielding means ear discharge. With the ear discharge you can hear better. Why? Because it causes the discharge will close the round window and you can hear the sound at a time. It cannot produce over the two windows. Okay, so that's why you can hear very well. Okay, if the discharge will be absent, if the ear will be dry, so the oval window and round window will expose to the sound at a time, so they cancel each one's effect and you can't hear anything. Okay, that is called as round window shielding effect. Okay, so the patient can hear better in the presence of discharge, and so the discharge will close the round window, so the sound waves strike the oval window and it goes inside. If you have a dry perforation, very big perforation, the oval window and round window will expose to the sound waves at a time, and the sound wave will hit the round window and oval window at a time, and they cancel each one's effect and you can't hear anything. Okay, right. So as we discuss. Okay, yeah, with the continuation of the signs, the tympanic membrane, there will be a central perforation. Okay, and the middle ear mucosa will be congested and there will be a polyp. You can see a polyp here, and ossicular chain usually not eroded. Okay, you may be having a erosion also, and you will be having a tympanosclerosis. Tympanosclerosis means there will be a calcified layers over the tympanic membrane. It is a separate topic. Let us deal separately. Okay, what are the types of perforations? Which type of perforation you can see in the tympanic membrane over the tympanic membrane near CSOM? Let us see. You have a inner mucosal layer. So there are three main layers. One is epithelial layer, second one is fibrous layer, and third one is mucosal layer. Okay, the mucosal layer is continuous with the mucosa of the middle ear. Here you can see this is outer layer, outer epithelial layer, which is continuous with the external artery canal, the middle fibrous layer. Okay, this is on the fibrous layer, and the inner mucosal layer, which is continuous with the mucosa of the middle ear. Here you can see in the histology. Okay, when perforation is there and it heal itself, if the tympanic membrane will heal itself, it heal by only outer epithelial and inner mucosal layer. There will be absent of the fibrous layer. This is very important question for the MCQ pre-PG exam. So what is central perforation? The definition is important. Here these all questions you will be encountered during your Viva exam. Okay, the central perforation means perforation of the pars tensa which is surrounded by a pars tensa, means there will be a remnant of the tympanic membrane. Okay, see again it is small perforation. It is in only one quadrant. That perforation will be, it is in anterior inferior quadrant. Okay, so it is called as small perforation. And medium size perforation, it is in two quadrants. See, you can see the perforation is in anterior superior and anterior inferior quadrant. Okay, it is around 10 to 40%. This is in pars tensa. This is medium perforation. And large perforation, it involves 3 or 4 quadrants. Okay, and subtotal perforation, this is very okay. What is subtotal perforation? Means the perforation in the pars tensa which involves all the 4 quadrants. See here you can see it is involved all the 4 quadrants, and the perforation is, it have a remnant of annulus tympanicus. This is the annulus tympanicus. Can you see this? And this is surrounded by annulus tympanicus, and it has all 4 quadrant perforation. Okay, right. There is a one term called total perforation. In the total perforation, this annulus also will be lost. Okay, so total perforation, all 4 quadrants along with the annulus tympanicus destruction. Okay, traumatic perforation with the trauma. See, whenever you have a trauma, see, can you see the blood stain near the tympanic membrane? Okay, perforation, you will have a blood stain near the perforation, and in traumatic perforation you will be having a irregular type of perforation. Can you see, it is very, I mean the margins are very irregular, and if you can observe in the central perforation the margins are uniform. Okay, so that is the differentiating point between the traumatic perforation and central perforation. Okay, so stages. As we discuss, what is active stage? Active stage is discharging at the time of examination. Okay, during your examination it is discharging. And what is quiescent stage? It is in recent past the discharge present, but there is no discharge right now. Means last week there is a discharge, or last month there is a discharge. Now the discharge is not there. Inactive stage means at least 3 to 6 months there is no discharge and there is a dry ear. Right, these are very important terms. You need to know what is active stage, quiescent and inactive stage. You will be get questions during your Viva. And healed stage means the tympanic membrane is already healed and there is a permanently controlled middle ear. With the healing perforation, the tympanic membrane will heal by 2 layers, the outer epithelial and the inner mucosal. There won't be any fibrous layer. So what are the investigations? How you proceed? Examination under microscope, ear discharge swab for culture and sensitivity, a pure tone audiometry for how much hearing loss with he present, and X-ray mastoid with the any bony destructions. Okay, and treatment options. Again you have a medical treatment and surgical treatment. Let us see the medical treatment, and the treatment goals will be elimination of the infection and control the ear discharge, and long-term goal is improvement of the hearing and with the healing of tympanic membrane. Okay, there should not be any perforation of the tympanic membrane. You should close that perforation. Okay, that is the long-term goal. Okay, so medical treatment. So what are the precautions you should take? You should avoid contaminated cold food, and you should you should not pour water into the ear. Okay, so avoid water entry into the ear. And oral toilet, the whatever the discharge, you should clean it with the suction, micro suction. You can clean it. Dry mopping and wet mopping. Okay, dry mopping usually we use with the cotton. Okay, we clean the external artery canal, whatever the discharge. Okay, right. If there is a thick adherent discharge, we use the wet mopping. Okay, antibiotics, again a systemic antibiotics for 1 week, like generally we use 3rd generation cephalosporins. If they are resistant to that, again next line is ciprofloxacin, generally what we use in our clinical practice. And topical antibiotic drops like gentamicin, ciprofloxacin. Okay, ciprofloxacin is a aminoglycoside, right? No, here gentamicin is a aminoglycoside. Okay, right. Antihistamine, again it is systemic and topical antihistamine. Generally we use systemic antihistamine like cetirizine, levocetirizine. And nasal decongestion, as the disease it starts from the nose, eustachian tube, so you have to decongest the eustachian tube, so you have to put the drops into the nose. Okay, like otrivin, xylometazoline, oxymetazoline drops into the nose. Okay, and you should control the primary respiratory infection or allergy. Okay, the systemic antibiotics will take care of. And allergy, sometimes you need to put a short course of steroid also. So what are the precautions? So you should encourage breastfeeding. Okay, and if the child's head is raised, and avoid bottle feeding, avoid forceful nose blowing, and avoid water entry during swimming and bath. Okay, and avoid putting oil, water, or whatever the material into the ear. Okay, and oral toilet, again it is done in active stage, dry mopping with the cotton and suction clearance and gentle irrigation, means with the saline you can do that if the thick material is there. Okay, this is dry mopping and wet mopping. So topical antibiotics, as we discussed, ciprofloxacin, gentamicin, tobramycin. And systemic, it is for polyp and granulation. For oral antibiotics, generally for severe infections. So these are the classification of antihistamines, generally used antihistamines: chlorpheniramine, cetirizine, fexofenadine. Fexofenadine and loratadine are new drugs. They have very less sedation, okay, or no sedation. And topical decongestions, oxymetazoline, xylometazoline. Okay. Chemical cauterization. What is chemical cauterization? With trichloroacetic acid, if you apply over the gently, if you apply over these margins. Here, in a case of perforation, the margins, they will evert and they won't heal. Okay, the perforation won't heal. So that's why if you remove gently this epithelium, if you remove this epithelium, and if you give you time to heal, it will close. The small perforation will be closed by itself. Okay, so the principle is the epithelium covering the margins of the perforation is destroyed and exposing to fibroblasts. It will promote the healing. It causes hyperemia and secondary fibroblast proliferation, and it causes healing. Okay, and it is used in dry to medium sized perforations, and you require several settings. Okay, so this is the principle of chemical cautery, where see these are the margins of the tympanic membrane. So if you apply a chemical cautery here, there will be after, if you give some time, there will be a healing. Surgical treatment, this is very, very important. It is indicated in inactive or quiescent stages. It is either Myringoplasty or tympanoplasty. Okay, and if you have a if it is in active stage, you need to open the mastoid also a surgery called cortical mastectomy. What it is later we can discuss. And sometimes if you have a polyp, you need to remove polyp. Here I want to stress the two terms, myringoplasty and tympanoplasty. Myringoplasty and tympanoplasty both are technically same, but the difference is in tympanoplasty you will enter into middle ear and you will check the status of the ossicles, and if anything is there you will repair also. Okay. So let us see myringoplasty. It is surgical closure of the perforation of the pars tensa of the tympanic membrane without touching the ossicle, without ossicular reconstruction. Okay, this is very important. Aim of the myringoplasty is to stop ear discharge permanently and make the ear dry and safe, and improve the hearing with the closure of the tympanic membrane perforation. Okay, and prevent the ongoing complications like further hearing loss, tympanosclerosis, adhesions, mucosal bands. Okay, and if you want to put a hearing aid in a old age, if the chronic discharging ear and there is a perforation, you can't put a hearing aid. So that's why you will have a air-tighted or seal. You have to seal the middle ear. So that's why put a graft and close the perforation. Okay. And occupational, in military and pilots, if you have a perforation, you will lose your job. Okay. And recreation like swimming and diving, every time with the perforation, if you dive, if you do swim, you will have a chance of infection. That's why you have to close. Okay. These are the aims. And myringoplasty, prerequisites of the myringoplasty. This is very, very important. They used to ask in the exam every time. The first one is dry ear. The ear should be dry at least for 3 weeks, and there should be very cochlear reserve. Means cochlear reserve means air-bone conduction gap. Okay. And third point is very, very important. You should be having a normal eustachian tubal function. Without normal eustachian tubal function, you cannot do a myringoplasty. If you do also, it will fail. Okay. And the disease, the myringoplasty is for predominantly conductive hearing loss, and there should not be any cholecystoma or a unsafe type of disease. Okay. Contraindications, where you should not do with the purulent ear discharge. If you have a discharge ear, you cannot put the graft. And if you have a otitis externa, means inflammation of the external aortic canal, you cannot put the graft. If you have a respiratory allergy, first treat that and then do surgery. Okay, with active allergy, respiratory allergy, you cannot do. Okay, and if the age is very less than 7, again you cannot do. Why? Because eustachian tube not fully developed. And only hearing aid, it is a relative contraindication, you should not. And cholecystoma, you have a separate surgeries for cholecystoma and unsafe type of disease. The myringoplasty is not indicated. Methods. Here there are few terms you should know. I will again explain you in later classes about the tympanoplasty. Here the terms you should know is underlay technique. Underlay technique is you are taking a graft to close the perforation and you are putting the graft medial to the fibrous annulus. Overlay means the graft you are placing lateral to the fibrous annulus. Okay. So what are the grafts you use? How you close that? Okay. How you close that perforation? You can close in that perforation with the temporalis fascia, tragus perichondrium, tragal perichondrium. You can take a vein and you can put it there, and you can take the fasciolata and you can put a dura mater also. Okay, these are all graft materials they usually ask. And underlay technique is the graft is placed medial to fibrous annulus. Overlay is graft placed lateral to the fibrous annulus. See the overlay technique here. This is tympanic membrane and this is perforation. Okay, this is the perforation, and here the graft overlay technique, you are putting over the annulus. This is the annulus. Okay, you are putting the over the annulus. Okay, underlay technique, you are putting below. This is the fibrous annulus. You are putting the below the fibrous annulus. To make it very simple, I will tell you one very simple thing. This is underlay technique, right? This is overlay technique. This is handle of malleus. If you are putting the graft below the handle of malleus, means medial, isn't it? This is medial side, right? This is lateral side. For example, if you imagine the patient is lying over the operation theatre, the ear, this is middle ear and this is external ear. He is lying over the operation theatre. Okay, so this is handle of malleus. If we are putting the graft below the handle of malleus, and this is underlay technique, and it is above the handle of malleus, it is overlay technique. Okay, right. Here I want to tell what are the advantages of the overlay technique and underlay technique. Okay, with the underlay technique, overlay technique, there will be a blunting of the anterior sulcus and epithelial pearl formation and lateralization of the graft. These are the three. I will explain when I deal with tympanosoplasty. It is blunting of the anterior sulcus, epithelial pearls and lateralization of the graft. With the underlay technique, you will have a problems or complications like middle ear will become narrow, graft may adherent to promontory, and it may lose contact with the remnant of the tympanic membrane. These are the complications. See this. This is the temporalis fascia. Abundantly you can take any amount of temporalis fascia over the temporalis muscle. And what are the advantages I will explain. The steps here: you take temporalis fascia, you open the middle ear. Okay, this is if you open the middle ear, you can see this is the incus, this is the stapes. Okay, and this is the flap. This is the remnant of the tympanic membrane. You lift it, and you should place the graft either by overlay technique or underlay technique. Okay, anyone. So this, after that you can reposition the flap. You can again see this is the incision, right? And you can again position back. Okay, it is very difficult to understand what is tympanosoplasty for you people. I'll show next class in some videos, you will understand. Okay, right, don't worry. See this, there will be a perforation. After the surgery you will have a closing of the perforation, right? So here you give incision, you lift it and you put the graft. This is the graft. Okay, and reposition the flap. Okay, why you need to take the temporalis fascia? Why not dura? Why not fascia lata? Means the temporalis fascia basal metabolic rate is lowest, best survival rate, and it is easy to harvest in a single incision, which is used for tympanosoplasty. And you can, in the same incision, you need to take the temporalis fascia. For example, if you want to take the fascia lata, you have to give the incision is very far. Okay, you have to give one extra incision. Okay, but for the temporalis fascia, with the same incision you can take the graft and you can do surgery also. And large size graft, any size you can take. Okay, this is autograft. There won't be any rejection, and it has the same texture and thickness as the normal tympanic membrane. Okay, and it is very resistant to infection also. Here the tympanosoplasty, it is the operation to eradicate the middle ear disease and to reconstruct the hearing mechanism. Okay, here the basic thing between myringoplasty and tympanosoplasty is, in myringoplasty you won't touch any ossicle, you won't check the ossicular status. For the tympanosoplasty you will check the ossicular status and you will reconstruct. Okay, here it is post-aural, Wilde's post-aural incision of the tympanosoplasty. Okay, you will give a incision here, you will lift the ear and you will go into the middle ear. Okay, Lampert's endoral incision. See, between the tragus and helix, crus of helix, there will be a no cartilage area. So from here you can enter into the ear and you can do surgery. It is called as Lampert endoral incision. Okay, and Rosen's transmeatal or permeatal incision via the ear canal, through the ear canal, external artery canal you can go. The best thing is here you won't have any scare outside the ear. Okay, but the ear canal should be very wide. Okay, for small ear canals you cannot do. So tympanoplasty is essentially 5 types. Type 1, 2, 3, 4, 5. Okay. So this is the classification of Wilde. Okay. Wilde classified this tympanoplasty into 5 types. Yeah. This is type 1 Wilde type 1 tympanoplasty. The defect is in perforation of the tympanic membrane. So you are closing the tympanic membrane. Okay. So this is technically type 1 is Myringoplasty. Okay. Type 2 is you have a defect in perforation of the tympanic membrane, along with there is a erosion of the malleus. See here there is a handle of malleus. Okay. So you put the red one is graft. Okay. So you put the graft here. Here there is no malleus, handle of malleus. So you are putting the graft on the remnant of the, see here, remnant of the malleus are over the incus. Here the graft is on the incus. So that is called as Myringoplasty or type 2 tympanoplasty. The type 3 is, see here, the malleus and incus is absent, only stapes is present. Okay. So you are putting the graft over the stapes. It is called as Myringoplasty. Right. Type 4 is only footplate of the stapes is present. See here the footplate. See the suprastructure is present. Here the only footplate is present. Okay. So you are putting the graft over the footplate of the stapes. Okay. So this is called as type 4 or cavum minor. Okay. Type 5. Okay. Type 5 is the stapes footplate is fixed and the round window is functioning. Okay. So you should make the another window somewhere else. Okay. So here this is the horizontal semicircular canal. You are making the fenestration here and you are putting the graft over this. So this is called as type 5. Type 6 it is not there technically. So you should remember only 1, 2, 3, 4, 5. Okay. 5 types. Okay. So with this I'll stop here. And here again type 1 graft placed on the malleus handle, type 2 incus, type 3 stapes head, type 4 footplate exposed, type 5 on the you are making the fenestration or the lateral semicircular canal and putting a graft. So here I'll stop, and next class we will discuss the another topic. Thank you.